Hi everyone. Hello if anyone's watching on the YouTube channel. So today we return to the University of Massachusetts. We're very fortunate to actually have this excellent team host in 2020. That was one of our first sessions. And I have to say, I'm still from that day terrified as to how to pronounce Worcester. I think that's how you do it in Massachusetts, but I'd be happy to be corrected. So Dr. Glandiak is the editor-in-chief. This is our team. This is our disclaimer. So as Dr. Glandiak mentioned, there's a little bit of growing pains in changing the format of the meeting and having people formally sign in. And the reason for this was, unfortunately, we had a couple of sort of hacks. And so this ensures that we don't have any inappropriate material during the recordings. So fun facts about Worcester. I try to mention something. So it's the birthplace of the first commercial Valentine's Day card. This was invented, I think, or created by Esther Howland in 1840. So maybe that's topical given that it's still February. Now, so I'd like to get Dr. Michael to maybe talk about the institution and his team. And again, we're very grateful for all of your time, both yourself and your team. And it'll be great to hear from you about your wonderful organization.
Great. Well, thanks, Vlad, for having us back. We remember fondly our experience back in 2020, and happy to be back now in 2025 to talk about a topic that's close to our heart, TaTME. We work at the University of Massachusetts Memorial Medical Center, which is partnered with UMass Chan Medical School, and we are the only tertiary care academic health center in central Massachusetts. And I am a hometown native. I grew up in Worcester, so great job pronouncing it. And after I completed my training, came back in 2005, and I've been here since. And we've developed a great team of 5 colorectal surgeons who are represented this evening: Dr. Alavi, Dr. Aulette, Dr. Sturek, Dr. Paponis. And we started a fellowship training program back in 2012. Our first fellow was Jen Davids, who spent a decade with us and is now section chief at Boston Medical Center. As mentioned here, we really do focus on our missions of innovative clinical care, which we'll talk about this evening, education, research, and community service. And we're excited to participate tonight. So looking forward to a stimulating conversation.
Thank you very much. So these are the photos of all the participants. That's great. So we have a poll that we'll discuss later. Look, unfortunately, we don't have many attendees at the moment, so there's probably not going to be a lot of people answering the poll. Hopefully, as they join in, as this recording continues, we'll discuss it later. But yeah, if you can tick your approach, that would be great to rectal cancer. Thank you. Okay, the first paper is titled Longitudinal Analysis of Local Recurrence and Survival After Transanal Radical Prostasigmoidectomy for Low Rectal Cancer Treated with Neoadjuvant Chemoradiation Therapy. This paper is from Lacanau in Pennsylvania, with the first author being John Marks. And I guess it's quite a unique paper, as we have a father and son, both as authors. Now, the paper will be presented by Dr. Gallant, and then we have Dr. Pepness to provide some expert commentary. So thank you very much, and start when you're ready.
Good evening. Thank you. So like Dr. Bolshinsky said, I'll be presenting the longitudinal analysis of local recurrence and survival after transanal abdominal and transanal radical proctosigmoidectomy for low rectal cancer treated with neoadjuvant chemoradiation therapy by Dr. Marks' group. So the transanal abdominal and transanal radical proctosigmoidectomy, otherwise known as the TATA procedure, was first introduced in 1984 for very low rectal cancers. Along with advances in neoadjuvant chemoradiation therapy and total mesorectal excision, TATA has maintained low local recurrence risk with excellent functional outcomes and quality of life according to other studies. The problem, however, exists in the gaps that are current along with the long-term oncologic outcome data for the TATA technique. The objective of this paper was to assess the long-term local recurrence and the survival outcomes after TATA following neoadjuvant chemoradiation therapy. And the authors hypothesized that TATA would have excellent local recurrence and durable survival rates over time. So the authors performed a retrospective review of a prospectively maintained rectal cancer database at a single tertiary referral center. Patients were included if they were 18 years or older with biopsy-proven primary adenocarcinoma that was located within 5 centimeters of the anorectal ring and had completed neoadjuvant chemoradiation therapy followed by the TATA procedure, as well as adjuvant chemotherapy as appropriate. The primary outcome was local recurrence rates, and the secondary outcomes were 5-year overall survival rates. On the right, we can see a total of 509 TATA procedures that were identified throughout this timeline, and the total of 321 were included between October 1998 and February 2021. According to the authors of this study, this was because the neoadjuvant chemoradiation therapy maintained similarities throughout this entire. The total sample size at the end of this was 255 patients. So like I had mentioned, the final sample size was 255 patients. The majority of these patients had clinical T3 disease, and approximately half of these patients had nodal disease. On average, the tumor height was approximately 1.2 centimeters from the anorectal ring. Among the resected specimens, all distal margins were negative. 1 patient had a positive radial margin, and 2 patients had rectal perforations. In 2014, the medical center started to report on TME rates, and so since that time, they had a complete TME rate of 94.3%. At median follow-up of 55 months, the local recurrence rate was 5.1% for this study, and the median time to the local recurrence was 29.6 months. The 5-year overall survival in this cohort of patients was 84.1%. And at the 5-year follow-up, the rate of stoma-free patients was 98%, which included 250 patients. At that time, 5 of those patients, which still had a stoma, ended up moving forward and receiving an APR. On the right, we see the long-term outcomes in the table, as well as the local recurrence locations of those 13 patients. So in conclusion, the findings demonstrate that treatment of very low rectal cancer with stage-appropriate chemoradiation therapy, followed by the TATA procedure, resulted in low rates of local recurrence over time in this cohort of patients. The authors advocate for more widespread adoption of the TATA procedure as an option for sphincter preservation, function, and stoma-free survival in very low rectal cancers. The limitations that exist in this study are the retrospective nature of it with its inherent biases, as well as the results, which reflect the expertise of a single center where the TATA technique was developed, which limits generalizability. Thank you.
Thank you very much. That's a great summary. Can we please have Dr. Pepnis make some comments about the papers in terms of what you think it provides us? Thank you.
Absolutely. Hello, everyone. Thanks, Dr. Gallant, for this great presentation of this paper. And thank you to the DCR team for allowing us to participate in this journal club today. So first, I would like to congratulate the authors of this paper. This was a really great paper. As we all know, it's the center that created TATA a few decades ago. And clearly, it's one of the largest. They have one of the largest, if not the largest, experience with this technique worldwide. And this particular paper is the largest series looking into long-term oncologic outcomes after this procedure for low rectal cancer. So just first off, I wanted to kind of like quickly review the technique, particularly for trainees that may be on the call, since this is not something that's very widely adopted. So just like the authors described in the paper, it's a bottoms-up approach. The procedure starts transanally. They start at the level of the dentate line, and they make a circumferential incision at that level. They get through the internal sphincter into the inner sphincteric groove, and that dissection is carried cephala towards the rectum and TME plane. And essentially, the external sphincter is, along with the distal end of the internal sphincter, are left intact, but they always include the proximal end of the internal sphincter with the specimen. Based on the manuscript, the patients that were included in this particular study had the remainder of the procedure transabdominally, either with an open laparoscopic or robotic approach. And the key here is to start the initial dissection from below, because the author suggests that this essentially guarantees a negative distal margin and also completes the arguably hardest part of the procedure with theoretically better visualization from below. I believe Dr. Marks and his group have published a few videos and have presented doing this technique, actually completing the entire case transanally, including the whole TME, IMA ligation, and even the splenic flexure mobilization, but we don't have to talk about this tonight. So this particular paper, the reported outcomes are really outstanding. They talk about the 5% local recurrence rate with a median follow-up of 5 years. And another remarkable thing in my mind is that 98% of all these patients ultimately had the diverting loop ileostomy reversed and were stoma-free. And I think these numbers are even more impressive if you consider the fact that all these cancers were in the distal third of the rectum, with, that's just like Dr. Galan said, the mean distance from the top of the anorectal junction being 1.2 centimeters. And most of these patients were male with all the challenges that this comes with. All of them had neoadjuvant radiation or chemoradiation, I would say. And a good number of them, about 35%, if I'm not mistaken, had a anteriorly located tumor. One of the things that I think is worth discussing is that not many colorectal surgeons or hospitals, including high volume rectal cancer centers, have experience with this technique. And I think we can all agree that all these cases are very hard in the OR, no matter the approach we choose. And I wonder just what is the number of TATA cases that one must do to feel comfortable doing this routinely, particularly, in the area of TNT and watch and wait, which comes with a decreasing number of LARs to begin with. And the other point that I wanted to make has to do with the functional outcomes of these patients. And I believe Dr. Marks's group published a paper back in 2017 in DCR. There was a smaller sample size, but they reported pretty good functional outcomes. So I'd be very interested to see these numbers in this much, this bigger cohort. And the question becomes, where do we draw the line? Of course, if you have the tumor at 1 centimeter from the ring and the patient is looking for a sphincter preserving approach, you don't have many options. But what do we do about the tumor that's 4 centimeters from the top of the sphincters? Do we have to get into the groove and remove the top of the internal sphincter along with the specimen? Is there any significant change in the functional outcomes? These were kind of like my thoughts. Overall, I think this was a truly great paper, and not just the sample size, which is impressive, but there's not many papers looking into 5 years of oncologic outcomes after a TATA procedure or TaTME. And I think it definitely makes a strong argument that this technique should be more widely adopted.
Thank you. I've got a few questions, and I'll probably direct them at Dr. Mako, and then he can distribute as he sees fit amongst the team. I guess the first question, and this is both for TATA and TaTME, is the impetus of what drove people to start this procedure. Is it the difficulty with transection, or is it the difficulty with dissection? Because particularly with the TATA, when they say the first thing they do is disconnect, and the rest seems like you can do it either way, whether you go from the abdomen or if you go from the transanal approach. It seems to me it's the transection which is the difficult part that people are trying to reinvent. Do you think that's accurate, or what, in your opinion, is the advantage of the transanal approaches?
No, I agree completely with you. I think that, there are always challenges with the narrow, particularly male pelvis following chemoradiation, in feeling comfortable that you have an adequate distal resection margin beyond a low-lying tumor, particularly those that abut the sphincter complex. And, traditionally we have ways to address that with a top-down approach. or in combination. For example, when we were being trained, being able to then go down to the perineal field, efface the anus, and perform an open division of the distal rectum to obtain a margin, and then typically that would result in enhanced zone coloanal anastomosis. But the beauty of this approach is that it basically, you can start the operation with the most challenging portion of it with an inline visualization, and you can define that distal resection margin and not have to rely on staplers that either don't angulate properly, particularly when you're minimally invasive, or even open staplers that are very difficult to maneuver beyond a large tumor or a thickened mesorectum and get to the point where you're comfortably below the tumor. So that's probably the reason why, you know, these approaches were initially thought of and considered, is, as you say, is really the definition of the distal resection margin and division of the rectum distal to the tumor.
Thank you. In the methods of the paper, the authors state the surgical treatment decision is made 10 to 12 weeks after neoadjuvant chemoradiotherapy during the preoperative assessment. Is this consistent with your practice? Do you base your treatment on the original staging? Have you changed your approach, particularly with the evolution of watch and wait or TNT?
I'll leave that one for Dr. Proponis.
So that's a great question. So I do think we all rely on restaging scans before we make a definitive decision about the approach we're going to follow for the resection. I don't think we necessarily wait for 12 weeks before we make that decision. I think it's usually along the lines of 6 to 8 weeks. We restage them and then we talk about it on the multidisciplinary forum and make a decision about the approach we're going to follow.
Thank you. To me, this seems to be a little bit of a gray area where there is no consistency. Perhaps I haven't reviewed the cancer guidelines, whether they've mentioned this or not, but certainly next set of guidelines might make that a special point. The last question I have about this study, I guess the data in the study ranges from 1998 to 2021, so that's 23 years. And obviously there are significant changes in chemoradiotherapy over that time, and also the staging assessment, ultrasound, MRI, and even just the quality of those tests over time have improved. And I guess my question is, from an interpretation of data, when you have a study which is so long chronologically, how do you critically appraise it? And perhaps for Dr. Alavi, how do you link that to a systematic review where arguably these studies have the same endpoints, but at the same time, you know, the quality might vary quite a bit over chronological changes?
Yes, thank you. And great presentation. And again, thanks for the invite. So I think regarding a systematic review, particularly in a study that ranges, I think that's what you're asking is like the studies that range a long period of time, how you can reliably understand or determine what their outcomes truly is, because chemotherapy is evolving, radiation is evolving. Some people are getting just chemo, some people are getting chemoradiation, you know, and it varies from center to center and is also individual based. So I think, you know, for a systematic review of this particular type of approach, I don't think the data is mature enough. Certainly if you just look at TATA, I don't think enough centers are doing it in a non-retrospective fashion, a more prospective approach that you could do a true systematic review. You could combine the data between that and TaTME, but then you have sort of you have a mixed bag, and it's hard to determine what the true outcome and what the true results are going to be. So I guess long-winded answer, the data is not mature enough to be able to give you that information. And you know, when you again particularly given the rather wide range of inclusion criteria or the date range, I think that, you know, while it's important because it shows our, you know, experience and you have long-term data, it then sort of muddies the water a little bit in terms of what else was used in the treatment.
Thank you. I can see Dr. Keller's joined, so she's the senior author on the paper, so thank you. I guess, can you tell us a little bit about the sort of your experience, I think, with TATA? You've moved to Lankenau a few years ago. Being part of it, is there anything that is different when you're kind of in the center that does it? Or can anyone do it in any other center? Like, how can people take the results of the study and apply it to their practice?
Yeah, and I think I can speak to TATA and introducing any new procedure in general. It is always better to do it in a specialized center, not just because of the experience of the surgeons, but also the experience of the team in the room and the team taking care of the patients and the ability to understand the patient experience and the surgeon's needs when operating. But with any procedure, standardizing the steps of the procedure, the instrumentation of the procedure, the cadence of when each step should occur, what to do if you're not following in that timeline fashion, rescue methods. I think that helps with safe implementation. Proctorship and mentorship are also essential for safely implementing a new technique, any new technique in an expert center, like where they develop the procedure. It's easier because they're physically there. Otherwise, telefenestration helps. There's apps that help, and phoning a friend even helps. And I think that those procedures can be applied to everything, including TATA.
Well, thank you very much. Look, I think that's quite informative, at least for me. Let's move on to the next paper, please. So the next paper is called Cytological Analysis of the Surgical Field During Transanal TATME for Rectal Cancer, a Prospective Study. And so Andrew, who is the presenting doctor, and then we have Dr. Tess Olet to provide expert commentary. Thank you very much to you both. Please start when.
Thank you for the opportunity to present. Like Dr. Bogazizi said, this is a cytological analysis of surgical field during transanal total mesorectal excision for rectal cancer, a prospective study. So transanal total mesorectal excision, or better known as TATME, has been a viable surgical method for rectal cancer resection with similar oncological safety compared to the laparoscopic radical resection rate seen in multiple previous clinical trials. Like Dr. Makel said, it offers an easier access and good visualization from below the pelvic space, especially in males with a narrow pelvis, severe obesity, or bulky tumors. Here, the problem was that in Norway, clinical trials showed that TATME led to a high local recurrence rate, with a local recurrence rate of up to 9.5%. And here they suspected the cause was that cancer cells might have spilled into the surgical area during the procedure, which was related to an incomplete closure with purse string sutures, which increased the recurrence risk. Now, the authors note that no prior studies had checked for cancer cells in the surgical field during TATME, which is why the study was important. And here they utilized the washing cytology, a method to detect cancer cells in fluid samples that's common in surgical oncology. So the objective here was to investigate the surgical field cytology during a TATME, and their hypothesis was that cancer cells may leak into the surgical field during the procedure, potentially causing recurrence. So how did they do this? They did a prospective single institution cohort study of 40 consecutive patients in Japan from June to December of 2020. Here they included any stage 1 through 3 primary rectal cancer that was less than 12 centimeters from the anal verge. And they excluded any patients that had recurrent or multiple cancers and any patient that had a local excision of the tumor. 18 of the 40 patients ended up having neoadjuvant chemoradiotherapy, and their primary outcome was presence of cancer cells in washing cytology samples. Here's a nice diagram showing how they ended up getting these cytology samples. So they divided the TATME into separate steps with 6 different times they got cytology samples. Here, after anal exposure with the Lone Star retractor, they developed the initial sample. Here they get 50 milliliter samples from each one. And then steps 2 through 5 are during the procedure. So pre-rectotomy, after rectotomy, pre-resection, and then post-resection. And then after the irrigation, final irrigation and anastomosis, they get one more sample. So in total, they had 40 patients. Again, 18 of them underwent neoadjuvant chemoradiotherapy with a mean follow-up time of 24 months. In the initial sample, 31 or 77.5% of the patients had evidence of cancer cells in their cytology. However, during the procedure, so steps 2 through 5, only 2 patients or 5% of the patients showed cancer cells, each in the pre-rectotomy stage as well as post-resection. However, the interesting thing was that the last sample, number 6, 0 of the patients had any cancer cells found in their samples. 4 patients ended up having an incomplete first string suture, and 3 of them had rectal perforations. However, none of these 7 patients that had complications ended up having a local recurrence. 2 patients did end up having a local recurrence, and here the 2 recurrences are outlined here. One recurrence had a neoadjuvant chemoradiotherapy and a lateral pelvic lymph node dissection. However, their washing cytology was negative at the end of the surgery. A nodular local recurrence was found on the left pelvic wall. In the second patient, this patient did not have neoadjuvant chemoradiotherapy or a lateral pelvic lymph node dissection. Their washing cytology was negative, but this patient ended up having 2 local recurrences, one on the left anterior wall corresponding to a positive pathologic CRM and a left lateral lymph node enlargement. In conclusion, they found that these cancer cells were reduced during the procedure of TaTME, and no patients have any cells in the final field. So, in conclusion, TaTME had a low risk of cancer cell dissemination during surgery if the surgeons carefully performed first strings twice and washouts. For cancer cell presence, they were detected initially, so 77.5% of them had cancer cells initially, but it was very rare during the procedure and absent in the final field, which suggests that TaTME can be oncologically safe with very careful technique, despite Norway's recurrence concerns. However, this is limited by a small study, but they only had 40 patients. It was at a single center, and they did need a little bit more follow-up to determine recurrence risk. And further steps for this study, further studies to confirm if cytology really does predict recurrence risk. Thank you for your time.
Thank you very much. That's an excellent presentation. I particularly like the slides in terms of where they have taken the cytology, and it was interesting that the cytology was positive initially in what I think is quite a high percentage of patients. Now, Dr. Olet, if you're available, please let us know what you think about the paper. Thank you.
Thank you much for having me. Great job, Andrew, for presenting this paper. I'd like to applaud the authors on a quite well-designed study, and I felt it was really quite thoughtful. I think when the results came out from Norway, I remember I was, a new, excited colorectal trainee and, really wondering, what do we do with this? How do we interpret this? Should I be learning TaTME? Do I want to learn TaTME? And so there was a lot of concern amongst the colorectal community for these high rates of local recurrence. I think we've already heard from the original paper, and there's several studies already out there, even our group presenting our experience with local recurrence, where we discuss, clinical outcomes. I thought this was a nice paper in looking at some additional objective data to kind of support the safety of this approach in TaTME. As authors mentioned, there were several hypotheses for why these recurrences were happening. And I thought that this study was a very methodical and well thought out approach to test this hypothesis that tumor cells might be present due to the inherent techniques of TaTME, whether it was insufflation or an incomplete purse string. So I think right off the bat, this is a really nice example of a study in which there's a hypothesis and then a very nicely designed, pretty simple experiment to test this. I think the authors chose to use cytology as a way to test for the cancer cells, which has previously been described and used in testing the efficacy of rectal washouts for rectal cancer. And there is data, to support using the cytology for why we might perform a rectal washout. And so in thinking about the methodology of cytology and the clinical correlation, it's funny that you mentioned that you thought this was high. I actually, in thinking about this, my initial thought was in the first washout, the cancer cells were 77%. And to me, this was a little bit lower, I guess, than I would have expected or hypothesized. And again, wondering, what is the sensitivity of this cytological exam? There were only 2 local recurrences, and none of these had cancer cells detected on the cytology. And so this begs the question, was the cytology not sensitive enough to detect them? Or were these truly unrelated and indeed, not present, and these recurrences were more related to the tumor biology? In my year working with Dr. Makel as the clinical associate, learning from the expert on TaTME, and one of the things that was really hammered home was, and I think very much highlighted in this paper, is the importance of technique and doing a really, really good purse string suture and how critical that is. And let me tell you, it is not easy to do. If you watch Dr. Alavi and Dr. Makel, they're going to make it look quite easy and, wizards at the purse string, but this is quite hard skill and you need to do it really well. It's very critical. This study had 4 incomplete purse strings they showed the pictures, which I thought was really helpful. I agree. They had a lot of very helpful and nice visual supplements to this paper. They also used a technique where they had 2 purse strings. The first one was done before the proctotomy. The second one was done after the proctotomy. This is not something that we routinely do at UMass. And so I think highlights the importance, again, of a good purse string, but maybe for more novice or beginner learners, doing a second purse string might be helpful. The thing that, again, technique-wise, if you're doing 2 purse strings in more distal tumors, may be a little more challenging for preserving that rectal cuff for an anastomosis. And again, why it seems that in their technique, they do this after the proctotomy. So whether they're just over sewing this to be able to do an anastomosis and preserve length. Overall, this was a small study. They didn't explicitly state the length of follow-up, but the recurrences were pretty short interval at 6 and 13 months. So I think further data with longer follow-up would be helpful to kind of be able to apply this clinically. But I think the big takeaways are the prominence of malignant cells were not as prevalent as initially hypothesized, and that, the surgical technique and purse string is really, really critical.
Thank you very much for that. I guess since we're talking on the purse string, the first question I'd like to ask is specifically, what would be some of the tips for people, Dr. Makel? Like I've heard of, double purse string. I've heard of glue after purse string. I haven't seen anyone use the barb suture, but I wonder if that would be a helpful thing. They're easier to suture with laparoscopically. What would you recommend people do?
Yeah, all great points. When we first started doing these cases, a lot of the time the purse string was done via an open technique, so sutured with a regular needle driver transanally. But as the procedure evolved, I would say the majority of the purse string sutures are placed a little bit more precisely under laparoscopic view, so transanally, laparoscopically. And so it starts with having good foundation skills with a transanal surgery. So whether you've been trained in TEM or a TAMIS or a TEO, I think being able to place a good stitch where your needle is entering where the last came out from. So not leaving any gaps, taking small bites, not large bites going across, because you really want that lumen to cinch up nicely. So nice bites into the submucosa. And I think that using a strong stitch, we use a 0 proline as opposed to something like a 3-0, so that when you do tie it down, and we tie it down open, you can really cinch down on it and feel confident that you're getting a good closure. And then before performing the rectotomy and dividing the rectal wall and potentially exposing the operative field to cancer cells, you want to confirm that you have a nice tight closure by evaluating that the lumen in actually probing it to make sure that it is literally watertight. And if not, placing an additional purse string to be sure that you're closed prior to dividing the wall of the rectum. I'd say those are some of the keys.
Thank you. I've noticed that Dr. Silla has kindly joined. Thank you. I guess my question, if you're available to answer, is related to sort of methodologies of a paper, something like this. I think it's a very interesting paper in terms of, looking for cytology. One of the things I wondered was, how do you have a control group where you're looking at sort of the same intervention in every single person, whether they should have a abdominal TME and do cytology on those? I guess in your sort of view of assessing TATME and the complications and potentially the multifocal recurrences, have you looked at different ways to sort of exclude random error or something like that from other studies?
No. Short answer. I think we have had the luxury, at least as part of the North American phase 2 trial in our procedure and assessment, to have video recordings of the procedures, because we felt this is a perfect opportunity. And I know Color 3 trial did the same. So they had systematic review, recording and review of the transanal videos. And I think that will be really telling, because as we're now starting to collect 3 years and then soon 5-year long-term data, or even perioperative outcomes, in terms of oncologic results, we'll be able to correlate them back to the video review of the procedures. And so if there was an event, and that I'll be really curious to see those cases where you have a local recurrence or some type of tumor implant along the pelvic sidewall, or one of those those horrible case scenarios of pelvic wall recurrence, going back to the video to see if you can correlate with an intraoperative event, like a problem with the purse string or dehiscence or something, I think will really be telling. And I think we should all do the same. I mean, I would hope to say that in 2025, whenever there's a complication, we make every effort to record our procedures and go back and see if it's a technical problem. Which in this case, we think it's more technical than biologic. That's what we think.
Thank you. Dr. Makel, I have a question for you. Now, I'm a simple person, and I try to keep surgery simple. And I like using betadine to basically rub anywhere where I think there's a remote chance of some sort of contamination. And I really have very little evidence that it helps. What is your take on how do you quarantine a proctotomy or a colotomy for cancer surgery? Do you think it makes a difference? What do you do?
I would say, as it relates to TATME, because of the concerns of introducing a new procedure, I think a lot of the early people, obviously Pat Silla has joined us graciously tonight, were particularly cautious to take every potential step in order to hopefully prevent there being from any negative outcomes from the operation. So from the beginning, we have been initiating the operation with the betadine irrigation of the rectum. And whether that potentially sterilizes any of these cancer cells that were identified on the study, I can't say that study has been performed as it relates to TATME, but it can't hurt. And we continue to maintain that practice to this day, where at the beginning of the operation, we will betadine irrigate, wash the rectal lumen prior to starting the operation.
Thank you. I always feel guilty when sometimes, more for sort of transabdominal procedures, I forget to wash out and then I kick myself, and I haven't seen a difference, but I feel guilty. I guess my last question to everyone is, we've had one study about TATME and one study about the TATA procedure. And so what are the differences in them in the broad terms? Is it an evolution of one into the other, or at some point are we going to differentiate them? And in terms of complications, you've mentioned technical issues. Is it an issue related to insufflation? And if so, is it a particular insufflator that we're blaming, or is it technical, purse string, anastomosis, that kind of stuff? Anyone who's interested to comment, greatly appreciate.
Well, I'll comment on the procedure-specific complications. There are potential risks and complications to every operation we do. And what we've learned over time is that there are procedure-specific complications for TATME. And namely, I would highlight the possibility of a CO2 embolism, because remember, we're insufflating high flow in a very small space. And the second is the potential risk of urethral injury at the time, particularly when we're talking about doing that dissection for low-lying rectal tumors. Now, because these two complications have been defined, we've done a much better job of preventing them from happening. But they both reflect technical errors. And they're typically a result of wrong plane surgery. And the issue with whether it's TATA or whether it's TATME, it is a new dissection field that, unless you've done it, nobody is familiar with. So when I finished my training, I had never seen a retrograde dissection of the rectum, particularly laparoscopically. And so it's understanding and learning a new anatomy, new landmarks, where to stay safe. And typically when people run into problems performing this operation or other operations, it's when they get off plane, they put a hole in the rectum, they get into an adjacent organ, they get into blood vessels where CO2 can insufflate, they don't have a good technical purse string, and cancer cells can spill. So I would say that just like Professor Heal taught us when he traveled the world in the 1980s about the importance of a technically perfect TME, I think it's important that we remember that lesson as we continue to introduce new procedures, new technologies, new dissection fields, and the critical aspect of technique from a surgeon's perspective and the impact that it has on a patient.
Thanks for that. I guess it was supposed to be about the poll, but unfortunately we haven't had as much of an attendance as we anticipated. So I think let's skip that. I might take up Dr. Silla's comment from before, which I think she put in the chat about the results of the COLA-3 trial that was presented 2 weeks ago. Whether you would mind just summarizing that for us, because I certainly haven't heard about it yet.
Yeah. So it's really fresh off the press. We didn't really post the slides at the meeting on social media at the request of the primary author, Jorian Tunium, because he is in a process of preparing the manuscript. But you know, these were quite incredible, and this is really coming in the footstep of the Chinese trial, the 3-year oncologic results that were published in JAMA, right, just 2 weeks ago, showing essentially no increased local recurrence in the transanal TME cohort. So that's really good to have that data. This is over 1,000 patients, over 500 in a TATME versus laparoscopic TME group. So the COLA-3 trial, essentially, they presented, and that was a 2-to-1 design for those who don't remember. It was 740 or so transanal TME versus half of that for the laparoscopic cohort centers around the world. And Justin actually was the only site with Kareem to enroll at UMass. All the other sites were in Europe and Asia. It's primarily China. This was a oversight, very tight and rigorous oversight by the Dutch. Amsterdam AMS really supervised the procedures. They had audits again of the videos. They reviewed the video quality. They reviewed the TME protocol. They reviewed the MRI. Every MRI had to be audited before patients were actually enrolled in a trial. So this again was a quite rigorous trial. I'm sure it will be accepted in a top journal. But the main punchline is no surprise. There were really no significant differences in the preliminary results. This was preliminary results. So there were no differences in terms of perioperative complication, intraoperative complications. There were no differences in CRM positivity, the distal margin positivity, completeness of the specimen. All the usual suspects were pretty much equivalent. And the only significant findings, which we knew eventually, it was nice to finally capture, we have seen in real world TATME practice, but it was really wonderful to finally see it captured in the trial, is there was a statistically significant difference in conversion rate. And the conversion rate for laparoscopic TME was 16% versus 0.6% with TATME, two-team TATME. And when they did a sub-analysis among the tumors 5 centimeters or less from the anal verge, it was even more dramatic. It was 20% in the less than 5 centimeter this from the anal verge for the laparoscopic TME. So we know that, we knew that, you know, every other randomized trial comparing laparoscopic to open or even robotic, you know, either excluded the 5 centimeter and below, or these were pretty much, you know, converted to APRs, as we know, with a very high rate of APR in that particular group. But this is, you know, this is where TATME is used in the real world and captured on the trial. It's being primarily used for those low tumors where you just cannot navigate and get below the tumor safely, and you have to perform some degree of intrasphincter resection in a large proportion of those cases. But the conversion rate is dramatic. So it was finally nice to see that capture in a setting of a randomized trial, because the medium tumor height was relatively low compared to all the other randomized trials that were published to date. But again, so it's reassuring, not surprising. We'll have to see the 3-year oncologic results, of course, but it was really nice to see, again, in a very large trial performed by very experienced surgeons, that really what we've seen, the benefits of TATME being for those very difficult tumors. Patients are obviously eager and eligible for sphincter preservation, that you now have a technique that's legitimate in the hands of experts. And so, you know, Justin and many of our TATME centers, and there's not many of us, are really hoping that this will revive an interest in transanal techniques. And, you know, what's really exciting is that we all understand and recognize that it's a moving field, right? It's not about how much of the TME dissection you do from below. It can range from TATA to intersphincter resection combined with then additional mesenteric dissection from below, mesorectal dissection from below. But it can also just be a rendezvous, what Antonino Spinelli calls TTSS, which is a single staple anastomosis, where essentially you've done all your dissection from above with a robot or laparoscopically, and you really know you're going to struggle, get your stapler below the tumor, and in order to just avoid it, you come from the bottom, just essentially doing that proctotomy just to connect with the abdominal dissection, and then place your purse string so that you can avoid the two staple lines, the whole nightmare of two staple lines, and you essentially can do a very nice single staple anastomosis and potentially have an impact on anastomotic leaks. Although we don't know that whether it's a factor or not. But I think now we have to think of not just TATME, but the spectrum, the range of things that you can do just to assist the abdominal TME. So we see this as transanal assistance, whether it's just a centimeter dissection combined with intersphincter resection or just do a connect. It's whatever it takes to be able to get below that tumor and try to achieve sphincter preservation in the patients who clearly would like to have it and are eligible to have it. In a nutshell. And hopefully those results will be published in the next couple of months.
Thank you very much. I'm sure Dr. Makel would be happy to be a reviewer for this paper to go into, say, DCR, which is a good journal.
He can't.
Right here.
He's a participant. He cannot be a reviewer. He enrolled patients in that trial.
I would accept with no revision.
All right. Well, thank you. Now let's move on to, we have a special guest segment, which we have for every journal club. And so I'd like to focus on Dr. Makel for this. So a little bit of a background. He graduated in 1998 from Tufts University School of Medicine. He completed his residency and then a clinical colorectal fellowship in the University of Minnesota, where I believe he was the best in his year. And I think Dr. Scott Steele was not equivalent in that award. Anyway, so moving after that, as he's mentioned before, he moved back to Worcester, and he is now the professor of surgery at the University of Massachusetts Medical School. Now, the aim of our discussion today is to, again, ask some questions pertaining to his interest in and experience in TATME. So thank you very much for your time. I might start with just a straightforward first question. Clearly, you were an early adopter of TATME, so can you please tell us how and why this came about?
Sure. So as you mentioned, I did my general surgery training at Beth Israel Deaconess in Boston, and then my colorectal training at University of Minnesota. And they were both very innovative, progressive centers. And I felt like when I finished my training, I was very skilled with minimally invasive techniques, and that included transanal surgery with TEM. And I started my practice at UMass Memorial back in 2005, as I mentioned earlier. And I was never fully satisfied with doing a low anterior resection laparoscopically. I was always frustrated with visualization, retraction, the smoke that would fill up in the pelvis and ruin your view, and you're pulling your camera in and out 1,000 times to clean. The stapler technology of being able to get below these mid to low rectal cancers. And so even though I saw myself as a minimally invasive surgeon, I did virtually all of my low anterior sections open. And I felt most confident in that approach and feeling that I was doing the best for my patients. And remember, this is 2005, really before, the robots were becoming popularized and before we had a lot of different products from industry. And then in 2010, in the same edition of Surgical Endoscopy, Pat Silla published her first case report of a transanal TME, and Matt Albert and Sam Mattel published their TAMIS platform approach for doing TAMIS. Amazingly, it was in the same edition. And fast forward 2 years later, I went to our ASCRS meeting. We wondered, why do we go to the meetings, and what do we get out of these things? And I remember sitting in a presentation by Antonio Lacey, and he presented his early experience with TATME. And Vlad, I swear, I was sitting in the audience and a light bulb went off. And I thought to myself, this approach literally solves all the challenges that I've been dealing with trying to do these operations minimally invasively or laparoscopically, as it relates to retracting pelvic organs, smoke evacuation, visual inline visualization, dividing the rectum distal to the tumor. And, it was clear to me that there was something here, thanks to visionaries like Pat Silla, who's joined us tonight. And so fast forward, again, it's amazing how these things evolve. But one of my medical school classmates, as you mentioned, I went to Tufts Medical School. His name is Matt Albert, and he is a colorectal surgeon down in Orlando. And they put together one of the first US TATME courses, and he invited me to come down and participate in that. And when I went down and I watched the didactics, the videos, and we did a cadaver lab, I came back to University of Massachusetts, and I remember, penning a note to Dr. Alavi and the rest of the team saying, I think I've seen the future of rectal cancer surgery. And I was completely sold on it. And I came back and we built a team. We began very cautiously, and we can talk about that to some degree. And to be honest with you, here we are 10 plus years later, and we've never looked back. And this is a critical aspect or a critical procedure that we offer our patients as it relates to those patients who are referred to us with mid to low rectal cancers.
Well, thank you. I guess the logical next question would be, what is required to become a competent TATME surgeon, particularly as, people who are early adopters, the rigors of assessment in an early adopter may not be the same as the rigors of assessment of someone who wants to start doing it now.
Yeah, so we've learned over the years that there are definitely prerequisites to launching a program. And I think it starts with having that excited, committed person who is either unhappy with their current way of doing things or is looking for a better way to do things. And I think it's really important to note that this is not what we call a YouTube surgery. It's not see one, do one, teach one. And TATME does not make rectal cancer surgery easy. So doing a low anterior section in APR is challenging, whether it's open, whether it's laparoscopic, robotic, or transanal. And so there's a process that you need to go through. And I think that in order to become a good TATME surgeon, you have to start with foundation skills. And so you have to already know how to do a perfect TME. You have to feel comfortable in the low pelvis. You have to be comfortable with performing a low coloanal anastomosis. You have to be good with laparoscopy. You have to have endoscopic skills. So either TAMIS skills or TEM skills, but able to manipulate your instruments, your angulated instruments in a very small field. And so in general, this is not really an operation that we're teaching fellows. The fellowship year is really about developing those foundation skills. And it's really about learning this operation and bringing all those skills together into one, complex operation, either through an advanced training program or as an attending. And so I think it starts with having a passion. I think second is having those foundation skills that have developed over time. And the third piece of it is really having volume. This is not a once in a while operation. This is something that you have to do regularly, routinely, and incrementally get better at. It's kind of like when people adopt robotics. They don't just sort of do a robotic case here and there. They really want to do all their cases robotically. So they get good, they feel comfortable, and they move past the learning curve. And at least most of the studies have suggested the learning curve for a TATME is somewhere around 40 cases. And so if you think about your own practice, think about how long it's going to take you to get to 40 cases until you really feel like you're expert at something. And so that's why it's important that when I came back from Florida and we introduced the program at UMass Memorial, we did it as a team. And so we cohorted our cases. We did the operations together. We made sure that we had adequate volumes, that we were doing them regularly. So you didn't do one case and then do another case 2 months later. This was like a weekly or every other week type of an operation until we really developed those skills and made our team expert.
Thank you. Can you elaborate a little bit on this, sort of on the lessons learned from developing a team for TATME in your center, or developing an approach to a new procedure in your center?
Sure. As I mentioned, it really was about building a team, and that team starts with the surgeons. And, fortunately, we were a group of 5 surgeons that could not only cohort our cases, but do cases together. But it's beyond the surgeons. It's the OR staff. It's the nurses, It's putting it together. These are big setups. They're complicated. Hospital administration needs to be on board. And then in the context of a rectal cancer program, it means having expert radiologists, pathologists who are really surveying your specimens. And so, that was a big piece of it, of building a team. The second is it does require an equipment investment. Now, back in, the mid, 20-teens, it was a little bit different than now, but, having the TAMIS access platform, I think, is a very important part of this. When Pat started doing it, she was doing it with the TEM and the TEO setup. And, most centers have transitioned to, exclusively doing it on the disposable platform. But also one of the early challenges was creating a stable operative field with a continuous CO2 insufflation and smoke evacuation. So you had a stable field to operate in. There wasn't any bellowing or issues with smoke accumulation that was limiting your view. So the air seal system and systems that provide that technology are critical as well. So you really do need a bit of an equipment investment. We talked a little bit about volume. And then a critical aspect of this is having the resources to create a database and follow your patient's outcomes. And so, over time, we have all published our studies, our experiences, and it's built the literature as it relates to TaTME. But at the same time, we didn't want to be doing any harm early on before we published our series. And so we were tracking our results patient to patient, making sure that we weren't having intraoperative complications, that we weren't having patients having unusual local recurrences as we were going, because otherwise our sort of internal DSMB would have shut things down and said, listen, we're looking to do a better job here, not a worse job. And so I think it's really important that you have the resources available to you to either contribute to international registries or databases or have your own homegrown database so you can track your outcomes in real time to make sure that there are no negative consequences to you introducing a new procedure or technology.
Thank you. I guess like many new techniques, with any new technique, there's excitement, and certainly there was a lot of excitement with TaTME initially, and then probably because people realize how challenging it is technically, the pendulum has somewhat swung, and together with this and the sort of era of social media, then you have the next new thing, which might be watch and wait, and so a lot of people have moved to that, and at least in Australia, it seems like TaTME has cooled. And so I guess my question is, do you think it is at a steady level now where there is a X amount of people who have adopted it and who are competent in it and who will maintain it? Do you think it'll still grow? What do you think the future holds for this procedure?
Vlad, that's the most challenging question you're probably going to ask me. I would say that I am very optimistic about the future of TaTME. I think there were a lot of people like me who initially were very enthusiastic because of the innovation, the potential, the solution to the challenges that we were experiencing as we tried to bring minimally invasive surgery to rectal cancer surgery. And early on, it was better understanding a procedure as it relates to the technical aspects of it and how to refine the operation and do it successfully without complications. But then it transitioned to obviously also tracking the oncologic outcomes. And as we've talked about, experience in Norway, potentially made people reconsider. Obviously, there is plenty of literature out there now, including now prospective randomized trials that prove the safety and efficacy of this approach. But, it is a difficult operation to perform. And the way that I see it is that this operation has made me a more comprehensive and a better colorectal surgeon. There's no question about it. And in addition to that, I can't tell you how many times I have said, my team has said, how in the world will we have accomplished that operation before we did TaTME? And it's like it's a skill set that just allows us to take rectal cancer surgery to the next level. As Pat mentioned earlier, it doesn't have to be a complete TaTME. So there are sort of spin-offs that come off of it. So this whole TTSS approach that Dr. Spinelli has been popularizing that suggests that just the distal transection and doing a single staple anastomosis, there may be benefit there as it relates to published anastomotic leaks in the range of 2 to 4%. So most people say the anastomoscopic leak rate following a low anterior section is 15 to 20%. So there's potentially a real benefit from that single stapled approach. When we looked at our series, our first 80 patients we did, 80% of them had received neoadjuvant treatment. They were all mid to low rectal tumors. The anastomosis was basically at the pelvic floor dentate line. Now, patients were diverted, but our leak rate was 4%. And so we know that there's a potential advantage from a leak perspective. It's also given me a comfort in managing patients who have had a failed anastomosis. And so what I mean by that is that by understanding the pelvic anatomy and having the skill set, we now help to take care of patients who have had prior resections, have had a failed anastomosis with a leak, and now want to be considered for a redo low anterior section, have had a rectal cancer recurrence. And we can now use these skills to approach that hostile pelvis minimally invasively or laparoscopically in order to resect and recreate an anastomosis, even when there's really minimal rectum left behind. So I think looking forward, we have to recognize that there's a real advantage to TaTME. It's a larger conversation, but perhaps most rectal cancer, as it's done in Europe, should be cohorted or centralized in high volume centers. And I think that at high volume centers, it makes sense to have this approach available for those patients who may benefit from it.
Hold on one second. Vlad had a technical problem.
Yeah,
He's reconnecting.
It looks like he's back.
I'm so sorry. I guess I am very far away. Look, thank you very much. I think it's time to close. Thank you for answering all my questions. I think that certainly will be very interesting for people to watch on the YouTube channel. I'm very grateful for the panel and the guests. So Dr. Keller, Dr. Silla, thank you very much for joining us as well. And so we'll be in warm Florida in the end of March. So please join us then. Okay. Thank you all.